Good evening, everyone. My name is Jen Nolan, and I'd like to welcome you to the 7th webinar in Arthritis and Osteoporosis Victoria's 2015 Musculoskeletal Health webinar series. Tonight's webinar will be providing us with an update on the topic of exercise prescription for the prevention of osteoporosis. Before introducing our presenter for this evening, I just have a couple of housekeeping issues to run through. Firstly, if you have any technical difficulties during the webinar, please refer to the message box on your screen. You can type a message at any time for the conference organisers at Redback Conferencing. If you're listening via the phone, you'll notice a small time delay between the audio and the screen. This is normal, so don't be concerned. Also, whilst our presenter will answer questions after the completion of his presentation, you can actually type questions for him at any time. Can I suggest you don't leave your questions to the last minute, as we will aim to finish no later than 8 p.m. Eastern Standard Time. I would also be very grateful if all participants could take a moment at the end of the webinar to complete the exit survey. It'll only take you approximately 30 seconds to complete. Our presenter for tonight is Professor Robin Daly. Professor Daly holds the position of Chair in Exercise and Ageing within the Centre of Physical Activity and Nutrition Research at Deakin University in Melbourne. He has over 20 years of experience in conducting human, clinical, public health and translational intervention trials to evaluate the role of exercise and nutrition for preventing and managing common chronic diseases such as osteoporosis, sarcopenia and falls. He's been an active contributor nationally and internationally to clinical guidelines in the area of exercise, calcium and vitamin D for osteoporosis prevention. He's a Fellow of Sports Medicine Australia and is a member of the Medical and Scientific Advisory Committee of Osteoporosis Australia. He's also the founder of the Osteo-size Strong Bones for Life community-based osteoporosis prevention, exercise and education program. Without further ado, I'll hand proceedings over to Rob. Thanks very much, Rob.
Thank you, Jen, and welcome everyone tonight to this webinar on exercise for osteoporosis prevention and management. So really what I wanted to do tonight is provide you with where we currently sit with the latest evidence with regard to exercise prescription for prevention and a little bit on management for osteoporosis and fractures. And so you may wonder why I start with a woman looking in the mirror putting some cream on her face. Well, I guess this is a common occurrence for most people. They're worried about their appearance and how they look on the outside, but in reality, if you could look on the inside and you actually saw your bones and they looked something like this, and you saw this osteoporotic bone, you can see whether the architecture and the structure of the bone is markedly deteriorated. You should be concerned, because having osteoporosis certainly increases your risk of having a fracture. And fractures can occur to anyone. Now, many of you may be aware or know this person, David Parkin, a former AFL player, four-time premiership coach. He used to work here at Deakin. I remember not long after he suffered a vertebral fracture, he came into my office and was explaining to me how he was running up or down a flight of stairs and he suffered a fracture in his vertebrae. And at the time, he thought he was actually having a heart attack and wasn't aware that he may have actually even have osteoporosis, or in this case, he suffered a fracture. So ultimately, fractures are the end point for osteoporosis. They're the most serious consequence, which is really what we're trying to prevent with either pharmacological agents or exercise. And there's good reason why we want to prevent fractures. And hip fractures are the most serious of all types of fractures. And if we look at some of the evidence about the consequences or morbidity or mortality related to fractures, you can see here in this particular graph, in 1 year of suffering a hip fracture, 20% of people will die, 30% will have some sort of permanent disability, 40% will be unable to walk independently, and 80% are unable to carry out activities of daily living. And I guess if you look at many of these consequences of fracture, there's one common theme that can affect most of them, and that's exercise. We know that exercise plays an important role not only in bone health, but also muscle function and preventing falls. And so I guess before we talk about the benefits of exercise, we really need to have a little bit of understanding of the physiology of what happens to our bones throughout life and on a day-to-day basis. And so this looks a little bit complex, this slide. It basically just highlights that our bones are very active tissues. And so our bones are constantly being remodeled, turned over. Old bone is being replaced with new bone to ensure we're in a healthy state. And so you can see here there's two particularly important cells. There's these little bone resorption cells called osteoclasts. So they eat away dead or damaged tissue. And through this activation, resorption, formation sequence, these other cells called osteoblasts lay down the bone and just typically replace the existing bone that was there with new bone. It becomes mineralized, and this takes sort of anywhere sort of 6 to 9 months for this to occur. Now, with osteoporosis, we know that these active osteoclasts tend to eat away the bone and less is actually formed or more is resorbed, and so we get this negative bone balance. And so that's how we lose bone throughout our life. So you should be aware that these little packets of resorption and formation are occurring all throughout our body, and they're at different stages of resorption and formation. Now, probably most important for you to be aware is that most osteoporotic drugs actually act to reduce bone resorption. They don't build bone. They try to stop the osteoclast resorbing bone. There's very few agents that are actually anabolic that build bone. And so it's very important to be aware that that is the primary function of most osteoporotic medications. So what are the strategies, or what strategies can we use to prevent osteoporosis and fractures? And typically they're divided into these three domains. So this is typically what we see if you have a bone density scan throughout your life. In the first 20 years of life, your bone density will go up, and that's when you achieve your maximal peak bone mass. And so those first 20 years are an extremely important time where you can, where exercise or other lifestyle factors can enhance bone density or bone mass. And so you can see here, if you can improve your bone mass during the first 20 years of life, and you're able to carry the benefit much later on in life, you may have a reduced risk of having a fracture. Now, for many of us, we're obviously past the age of 20 or 30, and so that's where we get a slow deterioration in our bone mass. And for women during menopause, they have a rapid reduction with the loss of estrogen, and then it tends to plateau out. So we can focus on trying to prevent or slow bone loss during the middle adult years. And so one factor in terms of trying to reduce your fracture, remember fracture is the primary outcome we're ultimately trying to prevent when we talk about osteoporosis, is trying to improve your bone mass or your bone density. And so you need to really have a handle on, okay, what is your bone density, and are you at risk if you've got low bone density? And so many of you will be aware that you can have a bone density scan or a DEXA scan, which will give you an indication of your hip and spine bone density. And the printout will give you a T-score or a Z-score. So a T-score compares your bone density to a 20-year-old, and it tells you, where do you compare relative to the young normal, and are you at risk of having osteoporosis? Now, you should also be aware, obviously, there's more to fracture risk than just having low bone density. And so as a result, some various groups and organisations have come up with these absolute fracture risk assessment tools, and this one's called FRAX. You can see the web address online. There's an Australian version or Australian country code you can select, and anyone can do this. So you can go and enter your information or your patient's information, click the various boxes, and it gives you your 10-year probability of having a fracture. And again, you can enter your bone mineral density if you actually happen to have that score. You can even do it without a bone mineral density score. And so this gives you a bit more information than if you perhaps just had a bone density scan by itself. Now, there's a glaring omission from this particular risk calculator, and some of you may have already picked it up, but one particular question which is not included is there's no question about have you had a fall. And this is really important because we know that having a fall or having falls is the major contributor to fracture. So there is an Australian risk calculator for those that might be interested as well. You'll see with this particular Garvin calculator, the number of questions they ask is much less. Typically it's age, and it's limited to those only age 60 or above. It asks you, have you had a previous fracture, but it'll also ask you whether you've had a fall in the last 12 months, and you can enter your bone density T-score as well. But if you look at the two figures on the right-hand side, you'll see here that I've entered the person who is 62, hasn't had a fracture, had either yes or no had a fall, or had a T-score of -2. And what you can see, if you've had no previous fall, but you've got low bone density, a T-score of -2, you've got a 6% increased risk of any fracture over 10 years. But if you said you've had a fall, you're at 16% risk. So simply asking someone whether they've had a fall in the last 6 to 12 months clinically can be very relevant. So it's important to also be aware that 50 to 75% of people that actually have a fracture don't have osteoporosis. They have osteopenia or low bone density, but they don't necessarily have osteoporosis. So that again highlights that we shouldn't just always focus on bone density as a key outcome when we're trying to prevent fractures in older people. And so this just highlights this point a little bit more. This was a nice little study which looked at the risk of having a hip fracture based upon your chair stand time, your leg power, your gait speed, or your grip strength, okay, independent of what your bone density is. So these little error bars, or sorry, these bars represent quartiles. So if you're in the fourth quartile, you've got the poorest chair stand ability, or the lowest leg power, or the poorest gait speed or grip strength. So you can see in this particular, in all the figures, generally, as your function deteriorates, you have an increased risk of having a hip fracture, regardless of what your bone density is. So it clearly highlights that in addition to measuring bone density, we should consider functional outcomes. And there's various functional tests that you can use. Unfortunately, they don't all have clinical cut points. They're not all routinely sort of available or easy to use, but here's a couple of tests that you may wish to consider. One of them is a grip strength test. And in this particular study, they're suggesting these are 2 cut points for men and women, which might indicate poor strength. Now, I know grip strength is not actually lower leg strength, but there's been a lot of research showing that grip strength is strongly related to a whole host of outcomes, including bone, muscle function, performance, mortality as well. So it tends to be a reasonably good estimate of someone's overall strength. We like to use this knee extensor strength tool, which is in the picture here. This is simply an IKEA chair. It's got a little strain gauge on it, and people are asked to push their leg as hard forward as possible, and it gives you an indication of their knee extensor strength. Now, currently, there's no consensus on the cut points. There's not a lot of normative data, so perhaps it's not that clinically relevant at this stage. Other common tests, which I'm sure you're probably familiar with, are the gait speed, so someone's walking speed. 2 very common tests are the timed 4-metre or 6-metre walk, and here are some cut points. Some people use 0.8 or 0.1 metres per second. The timed up and go is a very simple test, and we use the 8-foot 2.4 metre timed up and go test, which is simply sit on a chair, walk around a cone, and sit back down again. And again, a score of 8.5 seconds might be indicative of increased falls risk. So, in terms of clinical practice and just trying to get some sort of handle on someone's functional status, some of these tests might be very useful in the clinical setting and are very easy to perform. So when we talk about exercise, I guess I've given a lot of talks to GPs to try to understand or tell them about the importance of exercise, and we need to talk to our patients about not just telling them to go and do something or be active or just do walking, but to give them a little bit more information and a bit more prescription on what actually might work. And I think we're at the stage now with the evidence we've got from a whole lot of studies which have been done in the musculoskeletal field that we can be more specific in terms of telling what type might work, how often, the frequency and intensity, what equipment might be better than others, are there any interactions with certain nutritional factors or pharmaceutical agents, are there any adverse effects or risky exercises. So in terms of exercise prescription, this is what we've been working on through our research largely, is trying to fill in the gaps on this particular table so we can be, much like when you give someone a drug, you tell them all this information, exercise should be very similar. So the big question we always get is, does exercise, if you get people to exercise, does it actually reduce fractures? And this is a very difficult question to answer because not many people have really looked at fractures as the outcome. And to do the definitive trial to answer whether exercise prevents fractures, we probably need a 5-year trial with 7,000 or 8,000 people, which would be very expensive and very difficult to run. So this is a nice little review which just looked at various studies. You can see there's about 10 or so studies in this which had or reported fracture numbers in people that did exercise trials. And although the evidence is somewhat weak in terms of the strength of the evidence from the various trials, you can see in the figures here, Generally, in most of the studies, exercise reduced your risk or reduced the person's risk of having a fracture. So the 51% risk in overall fractures from the various studies that were conducted, and again, there's not many studies, but again, a 51% reduced risk is quite significant, and you can see also a reduction in vertebral fracture risk. So if we think about how does that compare to pharmacological agents, well, here's some of the common osteoporosis medications and the anti-fracture efficacy. You can see here it's around about a 30% reduced risk. Now, the evidence from these trials is perhaps stronger in terms of the study design, but again, the evidence for exercise would suggest that if you do it long enough and with a sufficient type and dose, you may actually get a reduction in fracture risk. But there's certainly other benefits than simply just looking at fracture risk reduction. So I've just posed this question. Unfortunately, you won't hear the sound come through on this little next slide, but I like to play this little quiz called Who Wants to Be a Millionaire? And so the question I've got for you all is which, if you were going to prescribe it, are the most safe and effective forms of exercise for reducing falls and fracture risk in a 60-year-old person who might have osteopenia that's low bone mineral density? I'll give you the options here. So PRT stands for progressive resistance training. So option A is resistance training, walking or balance exercise. Option B, resistance walking, hops and jumps. Option C, resistance hops, jumps and balance. And option D, walking, hop, jumps or balance exercise. So I want you to write down your answer, because at the end of the presentation I'll reveal which one of these is the actual option, but hopefully by the end of this webinar you'll be able to answer this question yourself without me providing you with the answer. Okay, so does exercise prevent osteoporosis? This slide is perhaps one of the most important slides because it's really a summary of where we're at with the evidence. So essentially, and many people may not be aware of this, but regular walking unfortunately has very little or no effect on improving your bone density. And the reason for that is that your bones have got these little cells embedded within them called osteocytes, which are the strain-sensitive cells. So they pick up strains or stimuli which are unusual or something that the bones are not normally accustomed to. And so it's only when strains go above a certain threshold level or some sort of stimuli that the bone thinks, oh, hang on, I've got to adapt and get stronger. And so generally most of us are either standing or we're walking at different times throughout the day. And so simply doing a little bit more walking or walking regularly doesn't tell these little bone cells to respond or adapt accordingly, because they're already used to that type of activity. So it really has no effect. There's some evidence that certainly suggests that brisk walking, hill walking, particularly for people who have been relatively inactive, may have some benefits on bone, but the effects are relatively modest. We know that resistance training, as long as it's progressive, relatively high intensity, can improve bone density. And you can see the effects are relatively modest into old age. We generally only get improvements of around about 1 to 3% or a maintenance of bone density with these types of exercise. So don't be disheartened if you get a maintenance of bone density, because typically you lose somewhere between 1 to 3% or 2% per year. So if you can maintain bone density, that's actually a good result. We know that impact type exercises are also important and can maintain bone mineral density in older people. Again, the question is, can they tolerate those type of activities? And I'll talk a little bit about that later. But probably most of the evidence would suggest that multimodal exercise programs, so a combination of resistance, weight bearing, and perhaps challenging balance activities are best. But if you look through the literature and you look at the evidence for the different types of programs, whether it's resistance, weight bearing, or multimodal, you'll still find that the evidence is rather mixed. And if you then look at the design of the various exercise programs, you'll understand why some of them are not effective. And many of them are not effective because, first of all, they don't have an adequate training dose. Second, they don't actually have progressive overload, so the exercises don't get progressively more challenging or diverse over time. And one of the key factors is the lack of exercise specificity. So that means basically targeting muscles or regions which are prone to osteoporosis or fracture, so your hip and your spine. Are you doing exercises that specifically target muscles around those joints? And compliance is often poor, which is always a challenge with exercise programs. So let me just show you some of the evidence around weight-bearing exercise. So there's been some nice studies which have looked at different types of weight-bearing exercises and trying to get a handle on, well, how difficult or what is the magnitude of load for some of these exercises. So we know with aerobic type exercises, we can measure our intensity by looking at our heart rate. But it's very difficult to do that with weight-bearing type exercises. But you can see through this particular slide, the peak force is basically the maximal load or ground reaction forces acting on the limbs from different types of activity. So simply walking or a lunge is only about 1.2 times body weight. If you start doing jumping or foot stomps, you can get up to 4 or 5 times body weight. Start jumping off a box, you can get up to sort of 9 to 10 times body weight. So it's good to have a sort of appreciation of the different types of activities and their the magnitude of the loads which they part on the body. But the other important point to consider is also the rate of force application. So how quickly loads are actually applied to the bone. So you can see in the red highlighted box here, a foot stomp and a jump both have roughly the same vertical ground reaction force acting upon the bones, but the rate of force application is markedly different. So you can see the foot stomp really puts the loads on the bone very rapidly, and that actually may be more osteogenic or more bone building than simply just the magnitude of load. So when we think about loading the bones, don't always think that high magnitude loading is important, because obviously some people can't tolerate that. And you may want to change the loading, either make it rapidly, or you can change the direction or the distribution of load, which is also important. So this looks a little bit complex, this slide, and this was sort of a bit like a heart rate intensity. We're trying to come up with an osteogenic index, or a tool to measure or estimate the benefits of different types of loading cycles on bone. And I won't go through it in detail, but there's just a couple of points to consider. First of all, if you look at the graph, when you load bones, they become desensitized to loading relatively quickly. And put simply, if you did 200 jumps, the bone would become desensitized, and so perhaps after 50 or 60 jumps, you would really get no added benefit to doing the extra loading cycles. And so basically, so that's a really important point to consider. You don't need a lot of loading cycles. Bones become desensitized, so become less adaptive to change relatively quickly, and then they also require some recovery time to become sensitized again. And so I guess the message here, if you look at the blue box or the blue writing and the green writing, if you look at this osteogenic index, and don't worry about so much the formula, but if you did 200 jumps twice a week, your index would be 32. But if you did the same number of jumps but did it 4 times per week, your osteogenic index would be almost double. In other words, that is saying that the benefits for bone would potentially be double by having dispersing the load throughout the week rather than doing it all at once. So what actually works and how much do we actually need in terms of weight-bearing exercise? So this, if you look at the blue graph, first of all, this is a study which looked at the effects of premenopausal women jumping on one leg either twice a week, 4 times a week, 7 times a week, and their other leg acted as the control leg. And so they were trying to work out, well, how often do we need to actually jump on a leg to get a benefit for our bone density? And so these bars represent a difference between the exercise and the non-exercise leg. So you can see here, 7 days per week was clearly the most beneficial, but it actually wasn't significantly different from 4. But these two were greater than 2 or doing nothing. So the message there is we probably need about, maybe 4 to 5 days of loading, and all they did in this study was 50 jumps. 50 jumps, multi-directional on one leg, either 7, 4, 2 days per week. So that's achievable for a lot of people, and it did improve bone density. So how many jumps do we actually need? This was another study we did in older men. This time they were 50 to 79. They did resistance training with a whole range of impact loading exercises. We then went back and added up all the jumps that they did and how much weight they lifted. And you can see from this graph, this is the percentage change in bone density for people that did less than 27 jumps on average over 18 months, those that did 27 to 50, or those that did 50. And what you see nicely here, doesn't matter how much weight these people lifted, if you did 50 jumps on average 3 times per week over 18 months, you got a bigger increase in your hip bone density or your femoral neck bone density compared to if you did less jumps. So the message from this slide is you don't need a lot of impact loading cycles, but you need to think of making the loads varied in direction and impact and sort of novel, so the bones don't become accustomed to the same thing again and again and again. Just another important point to consider, we know that osteoporosis, or what happens with your bone, it's not a uniform bone loss at all regions of your bone. And so in this particular picture here, the different color regions represent how thick your bone is at different regions of the hip. For example, you can see up the very top part of the hip, or this region up here, the bone is very thin. And this little graph on the other side with the red highlighted regions is been identified as one region of the bone that has this localized structural weakness, which has been associated with an increased risk of having a fracture. And so when we exercise, we should be trying to exercise, because we know it's very specific, to try to improve specific regions of the hip if that's possible, and designing exercises that might target particularly this top region, which is a little bit thinner. And is that possible? And so again, here was a nice little study which had these men this time do 50 jumps 7 days per week on one leg. The other leg acted as a control. And what you see here, these coloured little regions on these hip bones basically represents a change in bone mass from when they started the study. So the darker the blue, the bigger the change in bone density. So don't worry about the colours so much, but what is really interesting, you can see with the exercise leg, how you get all this quite dramatic change in bone density, even in the top part of the femoral neck, which is the weakest part. And so exercise, and all they did was jump in on one leg. So if you change the activity a little bit more, they might have even got bigger responses. But it just highlights the site-specific or the specific nature of exercise on bone. Interestingly, if you look at this particular study, which did the same sort of scans but gave people drugs, you actually see there's very little effect or site-specific effect of this particular example on hip bone density. Overall, it tended to improve bone density, but you can see giving someone a drug is not going to specifically target one region of the hip. It's not going to know to add more bone on the top region where it might be weakest. And that's why exercise is so beneficial. In terms of the importance of loading, again, the load magnitude, we know that high impact loads are particularly important for bones, and I won't go through the details of this particular study, but what it is essentially saying is that women did various impact loading exercises. They showed that it improved their hip bone density, but what they found was for the hip, the size of the loads was actually less than those that were needed to improve bone density at the lumbar spine. And that sort of makes sense because you know when you jump on your legs, the forces acting on the spine are probably going to be attenuated. But again, it just highlights that if you increase the loads on the bone, you're likely to get an improvement in your bone density. As I mentioned, the other important point to consider is whether loads are unusual or how the distribution or how the loads are actually applied to the bone. So this was a study again which looked at in athletes, and they divided them into different types of sports, basically high impact, odd impact, high magnitude, low impact, or non-impact. And what you see here essentially is that if you did high impact loading and odd impact loading, you are able to improve the bone structure or strength in the whole hip region. So again, the message here is unusual, diverse loading patterns are good for bone. What about resistance training? Well, we all know resistance training is generally good for bone. Unfortunately, if you do activities like this, it's unlikely to be that fantastic. Clearly, sitting down doing whatever exercise they're trying to do, sort of a shoulder extension type exercise, is not going to prevent a hip bone density. Now, this is a picture just taken from an exercise class where they're trying to get a large number of people doing exercise, so it's a bit misleading, I guess. But we know resistance training works if it's very targeted. And again, what type of exercises should we prescribe? And this is a nice little study which looked at the effects of resistance training on hip bone density. They found that resistance training worked, but these exercises were found to be the most effective. Leg press, hip abduction, and hip extension. Those types of exercises appear to be most strongly related to the improvement in bone density. So when you're designing your exercise programs, if it includes resistance training for bone, think very carefully about the exercises you're actually prescribing. Do exercises that are going to target specific regions around the hip, and these are some good examples. In terms of does exercise or resistance training prevent fractures, in terms of a very simple type of exercise program, in this particular study, they had these women do these back extension exercises. They did 10 repetitions 5 times per week for 2 years, and that's all they did. And you can see on this little graph here where I'm pointing with the pointer, over the 2-year period, this is back muscle strength. The exercise group had a much bigger increase than the control group, and 10 years later, after they followed them up, their back extensor strength was still much higher. But importantly, and I know the evidence is not that strong for this particular study, but importantly, those that did this very simple back extension exercise actually had fewer vertebral fractures over that 10-year follow-up period. So again, get to the message. My message here is a very site-specific targeted exercise program for the regions you want to improve is critical if we're trying to prevent falls and fractures. In terms of multimodal programs, we know they work, so programs with a combination of resistance and weight-bearing exercise. This is a study we did in older men. We were particularly interested in looking at whether exercise with calcium vitamin D fortified milk was more effective than just exercise alone or calcium vitamin D fortified milk alone. So you'll see there are 4 groups down the bottom here. This is the change in either spine or femoral neck BMD. And you can see from the 2 graphs, giving people calcium vitamin D plus exercise in this trial in men didn't result in any added benefits. The exercise was more beneficial than no exercise. And the reason we think the calcium vitamin D was not or didn't result in an added benefit is these guys already had sufficient calcium and vitamin D at the start of the study. So simply giving them more was of no benefit. But we know from example in Chinese women where they have very low calcium and vitamin D levels, if you do exercise with additional calcium and vitamin D, you can get some added benefits. But we didn't see it in this trial. As with most resistance training programs or exercise programs, if you target the muscle, you get improvements in muscle strength or muscle size, and we saw exactly the same in our program. So it was effective. They did do the exercise and improve their strength and mass. Interestingly, we got mixed results on muscle function. And so we looked at various measures of gait, balance, and sway. We saw a slight improvement in gait, but we didn't see some other important benefits in other functional measures. And we were a little bit surprised initially, but it's perhaps not really that unsurprising, I guess, given the nature of resistance training. So traditionally when you do resistance training, it's done in a slow, controlled manner. You are not training the muscles to move fast. You are training the muscles to improve their strength and their mass, typically. That's what the focus has largely been. And so many of these type of movements require rapid type limbs to move very rapidly. And so we're not the only ones to show mixed effects of resistance training on sort of functional outcomes. This is, again, a nice little review looking at the effects of resistance training on balance outcomes in older adults. And so they looked at a whole lot of studies, and the percentage figures in these different measures on the graph is showing what percentage of the studies that did resistance training showed an improvement in static balance, dynamic balance, functional, or some sort of postural measure. And you can see it's very modest. And so really only 15 of the 68 tests, 22%, actually showed improvements in balance performance with resistance training. And so it again highlights that just doing resistance training may not be that effective for improving functional outcomes. So in terms of falls prevention, what actually works? Again, this was a systematic review of a whole lot of randomized controlled trials. Overall, they found that exercise reduced falls by about 17%. But in this particular study, they went through and looked at, well, what type of exercise might be most beneficial? And so they looked at these rate ratios. Basically, if it's got a number of 1 next to it, there's no increased or decreased risk. If it's 1.09, it's a 9% increased risk of having a fall. And if it's 0.75, it's a 25% reduction in falls risk. So if you look at the various types of exercises which they looked at, the only ones that were beneficial in reducing falls risk were moderately challenging or high challenging balance or functional activities. Okay, resistance training alone, walking programs alone, stretching had no effect on falls reduction. And interestingly, if you look at their sort of multivariate analysis, which is trying to put everything together, again, they found that high challenging balances was effective. You had to do at least roughly 50 hours, so twice a week for 25 weeks. But interestingly, if you included walking in the program, it wasn't that effective and actually increased your having a risk of having a fall. Now, I'm certainly not saying don't do walking. We just need to be careful when we introduce walking into sort of musculoskeletal falls prevention programs. If you introduce it too early and someone has impaired function or balance, you might increase their risk of having a fall because you're encouraging them to get out there where they may not be so functionally capable. So just be very careful, and that's what this sort of evidence is suggesting. Our goal ultimately is to provide a falls prevention or improve their function and balance to then get them out there walking more often. This gives you an indication of some of the balance types activities you can do. I won't go through this in detail, but in terms of progression, you can see it's really up to your imagination in terms of trying to prevent or progress balance activities. And this book called Falls Proof It's got some great pictures and examples of how you can progress different types of activities. The other important point to consider is that many people fall over because they can't dual task. In other words, they can't do two tasks simultaneously. And so this is something we've been working on as well, is trying to look at programs where we can get them to exercise and do a secondary task at the same time. So we also, I think, should consider that when we're trying to train people, because it comes back to sort of cognitive function as well, which is really a strong risk factor for falls in older people. And we should consider sort of dual tasking or getting people to train like many activities of daily living. So for this woman here, you can see, does it really matter that she's got really good balance? Doesn't matter that she's got really good strength. Her objective is to cross this road to get to either the body shop or the pharmacy, not sure which one, in 54 seconds. So what she really needs is the ability to move her limbs really quickly to cross the road, so she can get to the shop on the other side. So you'll be pleased to know that she does make it with 15 seconds to spare. But the important point I'm trying to highlight in that slide is that often we focus on muscle mass or muscle size or muscle strength, and these decrease around about from the age of 45 to 50 years of age. Many people are not aware that muscle power, or the ability to produce force quickly, that's move your leg quickly, decreases linearly from about the age of 20 or 30. Yet very rarely do we train people in terms of trying to improve their muscle power or their ability to produce force quickly. And so we know some very interesting data from a recent study which is done in older people. They got them to do either high velocity training or doing the resistance training where they tried to move their limbs really quickly, or traditional resistance training. Now you can see here with the high velocity training, they only train at 40% of their maximal strength. With the high intensity training or the heavy load training, they trained at 70%. If you look at the various bars from the graph, there weren't much differences in muscle strength, size, or performance for doing high velocity training at a lower load. And this might be appealing for some older people because they might not be able to lift heavier loads, they might be scared of heavier loads, but we're training their limbs to move quickly. And so this was really the basis for our Osteo-size Strong Bones for Life program, which we're currently rolling out within the community. And I'll briefly talk about some of the results from this particular program. So this program was built really on probably on 10 years of research, where we thought, how can we actually implement a program in the community that's going to be safe, effective, and really be efficacious and can maintain its fidelity from the real work, from the research setting. So the program actually incorporates 4 key elements: an Osteo-size or a targeted exercise program, which I'll talk about. We have an osteo instructor or train the trainers workshop, where anyone that wants to implement this program within their facility has to do this trainers workshop and become accredited to be able to deliver the program as it's intended. We have an osteo adopt, so we try to incorporate behavioural modification strategies as part of the program to enhance compliance among the people involved. And there's an osteo ed, or an educational awareness program for the actual participants in the program to try to improve their knowledge around nutrition and exercise for osteoporosis and falls prevention. So we developed all these resources and manuals which we gave out to various exercise trainers when they were going to deliver the program, and they were specifically targeted at exercises around the hip and spine. So we gave them not 1,000 exercises. We gave them very targeted exercises, suggesting these are the best ones we think you should prescribe to really target the hip, spine, and the wrist to improve bone health. And so our program included a combination of traditional and high velocity resistance training. You can see the recommendations for the program down the bottom there. It included weight-bearing impact activities as well as challenging balance type activities. And so here's some examples of the resistance training activities. Now you'll note here, and I've only put this slide up to highlight that we don't always use machines. A lot of our activities, we try to encourage people to do them standing type activities. You can use different types of equipment. The idea is the program can be implemented within different facilities with different levels of equipment. Now clearly leg press is a very good exercise, but not everyone might have that particular machine. So you may consider squats. You can use dumbbells, weighted vests to change the type of activities. But you can see we do try to encourage standing type activities because it might have a functional benefit as well. Just a word of warning, upper limb exercises like the lat pull down can be sometimes dangerous, or what we find with many older adults is they suffer rotator cuff type problems, and so we try to avoid too many upper limb type activities where their hands are above their head. So what did we find? Well, basically this was an 18-month study where the first 12 months the blue region was very structured and we followed the trainers closely, and the last 6 months though basically left them to their own devices to see if they could still run the program. But you can see here the exercise program, like many other exercise programs, improved bone density at the hip and the spine, around about 1 to 3%, which is very similar to other programs. Importantly, we got significant improvements in our functional measures. So the sit to stand, the timed up and go, this 4-square step test, which you may not be familiar with, but it's basically stepping around in this little square forwards and backwards. Functional outcomes, which are very important, improved with this multimodal type program. And so very quickly, if you're going to implement these types of programs, I just want to mention we did some evaluations to get an idea of what the people liked about the program, and certainly working in small groups and socialising, you've probably experienced this in your own setting, was really very important for this particular program. They did enjoy having a set program and a structured program. The supervised sessions was really important. I think, and we've done this in multiple programs, one of the key strengths of any program is the exercise trainer, and the trainer has to have sort of a passion and a real genuine interest in the people, and they'll keep coming back to do the exercise if you sort of show that level of interest and support. Again, they said they liked the wide variety of exercise, so they didn't just go to the gym and lift weights. They did the weight-bearing exercises, they did the challenging balance activities, so they really enjoyed that. And you can see some other comments. They did enjoy the educational sessions to learn why they were doing specific exercises as part of their program. What didn't they like? Well, one of the things we probably pushed them, which they didn't, as they say, they didn't like, we probably pushed them a little bit too hard at the start, especially with the weight-bearing exercises. So certainly recommend you don't do those too early. You introduce strength first and then slowly do the impact exercise thereafter. The level of supervision did vary throughout our program, and they did probably like more supervision, and obviously the trainers vary from a day-to-day basis, which can influence their interest and compliance in the program. As an interesting point, they did say they needed more motivated trainers. They did like some of our trainers, but again, that was a really strong point that most of them made. The trainers were actually critical to the program, and they certainly struggled if it wasn't a group type session. They did like group-based exercise, and some of them did comment that things like the crowded gym and some more feedback on how they were actually improving might have been valuable, which is really important when you consider some of the simple tests that you can do. Some functional tests like the sit to stand and those types of things, you can introduce it because people will see drastic improvements really quickly. So I'm happy to say that the Osteo-size program did receive some federal funding from the government, and we're just finished our sort of initial rollout to see if it actually works in the community. So it may be coming to you somewhere soon, so keep an eye out for it. We did train up a whole lot of trainers to try to implement it within the community. So just for the last few minutes, I'll just, so these are my exercise guidelines. If you can sort of try to follow these principles, you're likely to have a program that's going to improve multiple musculoskeletal health benefits in older adults. So weight-bearing activities, they don't always have to be high magnitude. You can go to multi-directional, include functional activities like real day-to-day life activities which are functional and relevant to everyone everyday living, but are also fun and might challenge the bones. Resistance training is great. If you can, try to incorporate some high velocity resistance training. That's really for the lower limbs in particular. You don't necessarily need to do it for the upper limbs, but challenge them to try to do an exercise where they have to move it quickly, and certainly target the muscles around the hip and the spine. You can see the intensity of loading. Well, for resistance training, for the muscular benefits, originally I wrote a relatively high intensity, but some more evidence is suggesting that perhaps we don't even need to go this high for some older adults. But the key aspect here is it must be progressive. It must get progressively more challenging over time. In terms of frequency, look, it's probably somewhere between 3 to 5 days per week. Maybe 2 gym sessions, and then they could do 2 or 3 weight-bearing sessions at home where they might only need to do 50 or 60 or 100 jumps while the kettle's boiling or while they're watching TV. Very simple activities to do. Just make sure you teach them how to land properly if they're doing the jumping activities. And I've already mentioned this in terms of the duration. You don't need a lot of loading cycles. So just for the last few minutes, just some other exercises which have gained a sort of some publicity in recent years. You may have seen this, the whole body vibration, where you can give the elderly a good shake. There's different types of platforms. There's one that go up and down as in the picture, or some that go side to side. The evidence has been really mixed for these type of studies, except for this very nice study, because it was a long-term study over 18 months, included a large number of women, and they did find that whole body vibration training with exercises, so you don't just stand on the plate, you can actually do different types of exercises on it as well, tended to reduce risk factors for falls and fractures. So there may be a place for it in the facility. I think we need more work on it. We don't really know what frequency you should use, or how long you should stand there for. So I can't conclusively say it's going to be beneficial because the evidence is rather mixed, but this certainly, one study showed some positive effects. What about other forms of exercise? I often get asked about Tai Chi. Tai Chi is great for falls prevention. There's certainly some strong evidence that it can reduce falls, but it really has mixed effects on bone mineral density, and there's really no strong evidence that it's going to improve your bone health. And you can probably understand why when you think about the little osteocytes in your bone like stress, they like strain. Tai Chi are generally slow, controlled type movements which may not load the bone sufficiently to get an adaptive response. And the same probably applies to yoga. There hasn't been a lot of studies with yoga on bone in terms of whether it improves bone density. There have been a number of case reports showing that some yoga movements, especially forward flexion of the spine, can increase your risk of having a vertebral fracture. So just be very careful, because remember, many people, older people, do not know they've got osteoporosis. They don't know they've got osteoporosis until they've actually had a fracture. And so if someone has lost height, or they look frail, or you're concerned about their bone health, just be very careful if you're doing yoga, the type of activities you might get them to do, because it might cause a spontaneous vertebral fracture. Other activities which are interesting, some golf. Now golf is obviously a very dynamic type activity, which is rapid twisting, which some people are concerned, well, maybe that's a risky sport and may increase your risk of having a fracture. Look, there's no evidence to suggest that it actually does that, and we did a study to see whether golfers actually have higher bone density, and we couldn't actually see any difference. But again, I think one of the important points about golf, if you can get people to do some training, particularly trying to improve the core muscle strength, because we know improving core muscle strength is related to a reduction in falls risk. So include that as part of your program. It might be particularly beneficial. Now the big question we get is, okay, well, can you show me the evidence that for people with osteoporosis or people with fracture, that I can safely prescribe an exercise program that's not going to be dangerous and is going to improve their bone health and prevent their falls risk? Unfortunately, the reality is there's very few programs which have actually very few interventions or studies which have looked at exercise for people who have already got osteoporosis or have had a fracture. And so the evidence is really weak. So as a result, this group from Canada formed this initiative called Too Fit to Fracture. And they basically interviewed a whole lot of experts around the world and got them all together to come up with their expert opinions about what they think what the exercise recommendations are for people with osteoporosis or fractures, and what some exercises they should avoid. So I won't go through this in a lot of detail, but essentially their conclusion from these various papers, and I'm happy to share some of these with you because they contain some nice pictures and some recommendations for this higher risk group, would suggest that multimodal programs are probably best. And that was the general recommendation. Now that's rather broad and perhaps doesn't help you a lot, because when you've got your 75-year-old woman with osteoporosis, you need some more specific examples of what exercise you might prescribe. But this is sort of the starting point, and we're starting to look at some activities, some programs now for this higher risk group. If you've got this high risk group, I just want to highlight that bone might not be the actual focus. For these people who might have impaired function, might not be able to do the challenging resistance training or weight-bearing impact exercise, you might not want to, improve their bone density. And the emphasis perhaps is maybe improving their muscle function and reducing their risk of having a fall. And so if you see here, these are some of the key muscle groups which have been linked to function and falls risk. And so again, if you're designing a program for this higher group, think, am I designing or targeting muscle groups that are going to hopefully reduce this person's risk of having a fall? And so resistance training can work if it's sort of, again, targeted and maybe functional in terms of standing up. So you can use different types of resistance. You can use ankle weights. Just be careful with ankle weights because people have to lean over to put them on, which might increase the risk of having a vertebral fracture. So you just have to teach them how to put it on correctly. But things like using short lever arms. So if they're doing, for example, a rowing pulley where they've got to reach really far forward just to grab the weight before they can pull it out, that's potentially a risky type of movement. So it's the same thing as reaching in the back of your car to try to pull your groceries out. Again, that's a little bit risky. So you just need to teach them different types of activities or exercises to avoid until they improve their strength and you know that they're capable of doing it. But function, these groups, is probably the initial recommendation. And so coming back to our question, our little who wants to be a millionaire question. So hopefully by now you should have an understanding of what might actually work. And so the answer to this question, and unfortunately I can't hear you or talk to you, but the most effective program based on the current evidence is likely to be C, progressive resistance training with hops and jumps and challenging balance activities. And that's largely because we know that walking type activities, which was in many of the other answers, was not that particularly effective. So that's it for my webinar. I'm certainly happy to take any questions, and thank you for listening.
Thanks very much, Rob, for an incredibly comprehensive presentation. It was just so interesting to see all those studies and then to sort of see how you pulled it together, particularly with the Osteo-size program. I'd like to encourage people to write in their questions now. We actually don't have many questions listed, basically, I think, because the presentation has been so comprehensive. We've got one coming up here, but while we're just waiting for a few more questions to come, Rob, I'd just like to ask you, in relation to, just briefly, the issues you see with regards to translation into practice. When you're dealing with the trainers with the Osteo-size program implementation and so on, what do you sort of see as some of the key things that are acting as barriers or facilitators at the moment to what is really vital information?
Yeah, look, it's a very good question, and part of the challenge we're faced with is I guess the level of education for different trainers or their qualifications across from your Cert 3, your Cert 4 to your exercise physiologist. And so, when we talk to various governing bodies about exercise for people with chronic diseases, some people are concerned, well, shouldn't only exercise physiologists or physiotherapists prescribe that type of exercise? And I sort of would disagree in the sense because they're not probably enough of them out there in the community to really be able to cope with the large demand that's out there. And I think they're certainly fantastic for the first port of call to maybe recommend certain types of exercises to assess the person's level of risk. But then it's up to the trainers to then prescribe and supervise that exercise because not everyone can afford to have an exercise physiologist and see them on a regular basis. So I think that's one of the challenges we've been faced with is who can actually prescribe exercise for people that might be at high risk. And then some trainers are concerned, well, because you get people with high risk with osteoporosis, what exercises shouldn't I do? And ultimately then what happens is they then water down the program substantially, and so it's not an evidence-based program. So with these types of initiatives and with our Osteo-size program, I guess we're just trying to provide the best evidence out there so that people can then go back and hopefully prescribe an evidence-based program which is going to have the best benefits for that particular person. But it is, I agree with you, it's really challenging.
Rob, we have a question here. Can you recommend any spinal extensor exercises to use in an exercise class with osteoporotic clients who are unable to get on and off the floor?
Thank you, Jay. That is an excellent question, and to be honest, that is really challenging. Sometimes you can do different types of activities, like on a fit ball, or they can do even, they're kneeling on all fours, but they've still got to get down to the floor. So I'm not sure I can answer that question specifically, because when we look at spinal extension exercises, a lot of the ones are the line, the spinal extension on the floor. It's actually really quite hard to target spinal extensor muscles with different types of exercise. So even when you do like a rowing pulley type exercise, it's not necessarily spinal extensors. So I think in that case, what we generally recommend for those people is actually trying to teach them initially to get on and off the floor. And so it's not about targeting muscles, it's really targeting to get up and down from the floor. and then if they can, then you try to do a spinal extension exercise, because it's very difficult to do. Obviously, you can't do it stand-in type activity. So, look, I think we certainly need more work in that area for that really high-risk group that I guess are functionally incapable, first of all, in terms of they can't get up and down on the floor. But it's a very good question.
And Rob, another question from me. You mentioned, I mean, obviously the presentation focused very much on the elderly and older people this evening, but you also mentioned that in the first 20 years of life is really the time when the sort of maximising body mass and then, you know, the body mass is very important at that time. Like, is it a whole other approach with regards to maximising that opportunity in the early stage of life to increase bone density?
Yeah, look, the first 20, the principles for the first 20 years of life pretty much apply for what I suggested for the older people, apply in younger life as well. But what we find, obviously, there's not many studies which have really looked at resistance training for younger children, but we know that weight-bearing, high-impact activities, sports which are dynamic, tennis, gymnastics, volleyball, anything where there's lots of loads on the bone can certainly increase bone density and bone strength as well. And so, and importantly, we know that you get much bigger increases in your bone density. So in older adults, we might see 1%, 2%, or 3% net improvements. In younger children, we can see much greater gains. And so most of the evidence would suggest, or most of the evidence has been done, particularly during the early pre-pubertal and early pubertal years, appears to be the most optimal time. That's not saying, I mean, we haven't done so much work in adolescents. They're an interesting group and I guess more challenging given all the changes and lifestyle habits which change during that period. But certainly we strongly encourage weight-bearing impact exercises because they are particularly osteogenic for that age group.
Okay, Rob, it looks like you've probably answered everyone's questions. I must say, even on a personal level, I've been taking a few tips and hints for myself tonight. So I'm sure other people will be as well. Look, again, we're just before 8 p.m. Eastern Standard Time, so we might wrap it up there. Once again, Rob, thanks for what was just an incredibly comprehensive and fascinating presentation. And I hope that certainly, you know, the sort of translation into practice from what you provided us with tonight, at least it's a beginning. So we've got a couple of thank yous coming through, but from all of us, thanks, Rob. Could I remind everyone to just take a moment? The exit survey will appear on your screens very shortly. Just give it a few seconds. But I'd like to wish everyone a good evening and thanks very much for joining our webinar this evening. Good night.
Thanks, Jen.